Hi everyone, my name is Brynn Marks and I'm a pediatric endocrinologist here at Children's National in Washington, D.C. I'd like to thank Amy and the DiabetesMine team for having me here today to talk to you about improving diversity and inclusivity in type 1 diabetes care and research. To begin, I'd like to share a quote with you from former First Lady Michelle Obama. "Sameness breeds more sameness until you make a thoughtful effort to counteract it." Today, I'd like to start by presenting the facts about disparities in diabetes care before sharing some work attempting to identify the root cause of these disparities. Only by understanding the cause of these disparities can we then develop targeted solutions to ensure that everyone with diabetes receives access to the best possible care. Systematic problems demand systematic solutions, and I hope to show you that we as a community need to attack these disparities from multiple different fronts to further inclusive and equitable care. I know you've already heard a great deal about disparities from today's wonderful presenters, but I want to briefly highlight disparities in the type 1 diabetes community. I'll be showing you data from the Type 1 Diabetes Exchange, which captures information from just under 23,000 people in the United States living with type 1 diabetes. Although 23,000 seems like a large number, remember that this represents about 2% of the estimated 1.25 million people in the US living with type 1. It remains unclear just how well the data here represent the entire population. In this figure, mean A1C is stratified by years of age. White people are represented by the blue bars, Black people the orange bars, and Latinos by the gray bars. A clear pattern quickly emerges. The mean A1C is lowest in white participants and highest in Black participants, while Latinos fall somewhere in the middle. Next, let's turn our attention to A1C disparities by household income. The green bars represent people in households with less than $50,000 in annual income, blue, $50,000 to $75,000, purple, more than $75,000. Again, we can see a clear pattern. The lowest A1Cs are seen in the wealthiest participants, while the highest A1Cs are seen in those with the lowest income. Now let's consider the demographics of type 1 diabetes in the US. Among children less than 18 with type 1, you can see household income, highest parental education, and type of health insurance, all stratified by race and ethnicity. Again, the blue bars represent white participants, orange, Black participants, and gray Latinos. Those with the least income, those with households from the least formal education, and those with either no or public insurance are far more likely to be Black or Latino. While there are many factors contributing to disparities in type 1 outcomes, systematic racism is undeniably a significant factor. In the past decade, we've seen tremendous advances in type 1 care. Faster-acting insulins, ultra-long-acting insulins, factory-calibrated CGMs, and hybrid closed-loop systems. Now you might wonder, have those advances impacted members of the type 1 community equally? In the top figure, you see the percentage of patients in the type 1 diabetes exchange who are using an insulin pump, and in the bottom, you can see those using CGM. This is stratified by income, with participants from the lowest income homes in the far left and those with the highest income on the far right. You can see that those from wealthier households are nearly 3 times as likely to use a pump and 5 times as likely to use a CGM as compared to those with households from the lowest income. Next, shift your attention to the colored bars. The light blue bars show data from 2010 to 2012, while the purple bars show 2016 to 2018. The increasing gaps between those lines shows that the disparities have worsened over the last decade. Now you might wonder what happens in other parts of the world. What you can see here is that in Germany, there are no disparities in access to these technologies according to income, and that there's been no change in that status over time. Again, many systematic factors contributing to the problem here. Now let's think about the implication of access to technology on A1Cs. It's not surprising to see that there are also disparities in A1C by income. While there's a slightly lower mean A1C among the wealthiest in Germany, this difference is only 0.2 or 0.3% as compared to a more than 1% difference between the wealthiest and the poorest participants in the type 1 diabetes exchange. Now let's shift our attention to identifying the cause of these disparities. In a study of 300 young adults with type 1, a third Black, a third Latino, and a third white, Agarwal and colleagues sought to identify those causes. The mean difference in A1C between Black and white participants was a staggering 2.3%. 40% of that difference was explained by socioeconomic factors: household income, food insecurity, insurance status. 17% was explained by access to insulin pump and CGM, recognizing that other studies have shown that over half of participants who are not using these devices have never been given the chance to use them by their providers. 5% of the disparity was due to psychosocial factors: diabetes distress, depression, traumatic life experiences. And yet 30% of the difference still remains unexplained. This highlights the need for more qualitative research, using interviews and surveys, as you've seen today, to better understand the as of yet unrecognized factors impacting diabetes care and outcomes. Only by identifying the contributing factors can we develop strategies to address them. I'd also like to mention that the mean difference in A1C between Latino and white participants in this study was less than 1%, and that after controlling for socioeconomic factors, this difference disappears. This phenomenon, with better outcomes in the Latino community, despite lower income and less formal education, has been consistently observed in many different health-related outcomes. It is often referred to as the barrio effect, meaning neighborhood in Spanish, and recognizes the closeness of the Latino community in overcoming these demographic disparities. The barrio effect and the power of this community may even suggest potential approaches to improve care among the Black community. Might representation of research be something that is impacting these disparities in type 1 care and outcomes? Here you see demographic information from the most recent pivotal studies of hybrid closed-loop insulin delivery systems in the US. The 670G pivotal study in 2017 didn't mention race, ethnicity, or income. The Control-IQ pivotal study in 2019 included participants with a mean A1C of 7.4% and 11% Latino participants. Though they didn't specifically indicate how many Black participants were included, you might infer based on the numbers there. Most recently, the Control-IQ adolescent study in 2020 included 8% Latino participants and specifically stated that they included 0 Black participants in the study. In both of the Control-IQ studies, more than 90% of parents or participants had at least a bachelor's degree. Most came from households with more than $100,000 in income, and over 90% were privately insured. Researchers want to find strategies to improve care. However, doing so requires adherence to rigorous study protocols, maintaining frequent contact with the study team to ensure complete data. However, given the highly select group included in these studies, I wonder if we can generalize these results to the entire type 1 population. This begs the need to develop more inclusive, culturally competent studies that include and reflect the true population. Recent abstracts presented at the ISPAD meeting highlighted differences in diabetes technology uptake and discontinuation of use over time. Black children were less likely to start using a CGM and more likely to discontinue use at 1 year. Perhaps we also need to devote more attention to understand the factors contributing to disinterest and discontinuation of technology use, to better understand modifiable barriers to use and increase uptake in minority groups. Here at Children's National, with the support of Tandem Diabetes and supplies from Dexcom, we will be launching a study to explore the impact of Control-IQ on underserved populations, those who are the least likely to access CGM and insulin pumps. Our clinic serves a highly diverse population, including 38% with public insurance, 40% Black, and 11% Latino children. Specifically for our study, we'll enroll 30 youth ages 6 to 21 with type 1 diabetes who are the least likely to access CGM, pumps, and hybrid closed-loop systems. As we've discussed today, this includes non-Hispanic Black children with public insurance whose A1C is over 10%. Additionally, we will be including only participants using insulin regimens that don't require carbohydrate counting, such as sliding scales or NPH-based regimens. Over the 6-month course of this study, we'll be focusing on time and range as our primary outcome. We'll also be assessing incidence of diabetic ketoacidosis and severe hypoglycemia, treatment satisfaction, and quality of life. And perhaps most importantly, recognizing that we still don't understand the root cause of these disparities, we'll also interview participants and their parents to understand their experiences with the technology before the study and the impact of using these technologies on their outlook on diabetes care. In conducting inclusive research, it is important to consider how to define race and ethnicity. These categories are social, not biological constructs, and so people must be allowed to self-identify. The FDA has provided guidance on how to assess these constructs. Ethnicity should be presented first and should ask participants to choose between one of two categories, Hispanic or Latino, or not Hispanic or Latino. Participants can then choose from 5 different racial categories and may select more than one. These include American Indian or Alaskan Native, Asian, Black or African American, Native Hawaiian or other Pacific Islander, and white. Although research has been conducted at centers that have diverse populations, we've seen that studies attract a narrow range of participants. Research centers should seek to recruit participants that represent their population. In considering how to address the issue and how to conduct more representative research, we need to think about what keeps others from participating. Consider the burden of type 1 diabetes care and studies showing that those with type 1 will lose $500,000 over their lifetime to lost productivity and healthcare costs. Now think about parents who don't get paid unless they go to work. No vacation, no sick time. Even the compensation for time provided by many studies is not enough to make up for these lost wages. We must consider strategies to make research more accessible, increasing night, weekend, and remote participation when possible. Now also think about the mistrust of the medical community among minorities. For anyone who hasn't read it, I highly recommend The Immortal Life of Henrietta Lacks, which tells the story of a Black woman in 1951 Baltimore whose cervical cancer cells were taken without her knowledge and sold for billions of dollars to support research that has developed the polio vaccine, gene mapping, and in vitro fertilization. How can we address this mistrust? I don't have an answer here, only ideas. But one of the things I have noticed is that the children I care for respond better to a care team that is more like them. Recruiting diverse, representative care team members may be another potential solution to address these disparities. For too long, clinicians have created constructs of ideal pump and CGM candidates. After initial research showing higher rates of DKA among those in suboptimal glycemic control, many clinicians fear prescribing pumps to those with elevated A1Cs for fear of potentially causing harm. However, recent studies have shown that pump use is associated with lower rates of DKA. Back in 1995, Fran Kaufman's group showed that over 2 years, pump use in a high-risk group with a mean A1C of 9% and 5 hospital days per year was safe and cost-effective. In 2018, 10 Australian adolescents with A1Cs over 10% had only 3 episodes of DKA over 12 months of insulin pump use. We need larger, more inclusive studies to show the safety of using these technologies and to win the hearts and minds of prescribers so that we can combat this longstanding idea of the ideal pump and CGM candidate. We should also consider the financial arguments. Those can be most likely to win over insurance companies and have the potential to reduce disparities. Ever since a study showed that use of an ultra-long-acting insulin, Tresiba, decreased DKA admissions and was cost-saving, I've consistently gotten this insulin approved by insurance companies. I've been referring to societal disparities in income, education, and insurance that undoubtedly impact type 1 care and outcomes. While these societal issues and evidence of systematic racism are challenging to address, I do think there are ways we can work within our current system to foster community support, similar to what has been observed with the Barrio effect. Walker and colleagues at the University of Florida ran a small pilot study using college-age near peers to mentor a group of high-risk publicly insured teens with type 1. Although not adequately powered, they showed slightly better A1C outcomes, better rates of clinic attendance, and more hope for the future among participants in the mentoring program. In recognizing psychosocial stressors that are more common among minorities with type 1, we also need to develop strategies to address them. Corey Hood and colleagues at Stanford are using an intervention program focused on promoting resilience and preventing depression before there are signs of diabetes distress in adolescents. These unique approaches offer a potential strategy to combat societal inequalities while also improving diabetes outcomes. Finally, I have to address the elephant in the room, implicit and explicit bias, perhaps better termed racism. Implicit bias refers to unconscious processes that impact our decision-making. Racism today manifests itself differently than it did 50 years ago, through microaggressions, seemingly small daily behaviors that communicate a message that someone does not belong or is not valued. Eye contact or the lack thereof, calling on people in a group discussion, interrupting people when they're speaking. Concretely put, Black babies in the neonatal intensive care unit are more likely to survive when they're cared for by Black doctors than when they're cared for by white doctors. By acknowledging these behaviors through bias training, calling our individual behaviors into question, and creating accountability for our actions, we can work towards a more equitable, inclusive future in diabetes care. An unanswered question is whether there is explicit bias in clinician type 1 treatment. I certainly hope that there is no explicit bias, but do think that it merits further study.